Everybody, thanks for being here today. I'm a member of the Aurora Health Alliance board and excited that we're highlighting mental health, and May is Mental Health Month. And when we were talking about things that we thought might be of interest to the community, infant and early childhood mental health kind of rose to the top. I think a lot of people don't necessarily think about infant and early childhood mental health in that bigger mental health picture, but it's extremely important programs that our community can benefit from. So we wanted to make sure to highlight those programs for y'all today. So we're going to start with Christy, who is going to be talking about Child First and probably, I think, a little more broadly, early childhood mental health interventions.
I'm a licensed psychologist, and I will be presenting on Child First. Child First is actually fairly new to Colorado, and Aurora Mental Health and Recovery was part of its launch in Colorado starting around 2 years ago. Child First is an evidenced home-based home visiting program, but it's therapeutic in nature, and it is listed with all these lovely research kind of policy, but just to think about, like, there's a lot of research, and we'll get into it, about its effectiveness. So it's one of the promising practices in terms of infant mental health. So Child First is currently in 4 states full on, and just now, as in the last month or so, has actually included Pennsylvania and Louisiana. It originated in Connecticut with some research done at the University of Connecticut, and then has been primarily East Coast until Colorado a couple years ago, and then has been extending its reach. And it recently also became joined with the evidence-based home visiting program, Nurse Family Partnership. So on the national level, Child First and Nurse Family Partnership are actually combined, and I'll get into a little bit of like the differences between the two home visiting programs for early childhood. So here's my brain development in 30 seconds or less, which is really sometimes really hard for me to do. But really the takeaway point from this slide is that within the first 3 years of life, and some people call it the first 1,000 days, a lot of brain development is occurring. And this brain development actually really interfaces with the environment and a kind of use it or lose it kind of method. When you are born, you have a lot of neurons, and then through the process of the first 3 years of life, what happens is that these neurons either get connected to other neurons, or they kind of don't get connected, and then they kind of die off and do that. So lots and lots of brain development during this first 3 years of life. And this is really important when we think about the importance of mental health in the first 3 years of life. A lot of times people are like, oh, they don't remember. Like, most of us don't have a whole lot of memories before 3 years, but that's because of this brain development and connecting. But all of us are impacted by the brain development that happened during this critical time in development. We just don't have words for it. So I think that's an important thing to think about when we're thinking about early childhood. So one thing that we like to really consider during this time is this idea of toxic stress in the environment influencing brain development. And so toxic stress is really kind of having strong, frequent, or prolonged activation of the body's physiological response to environmental stress. So this is your fight, flight, or freeze. In typical development, in typical health, The idea is that you fight, flight, or freeze, and then the stressor goes away and your body returns to homeostasis. So what little kids need is that they actually need a protecting, buffering effect of a caregiver in order for their nervous system to kind of go back to to be at rest. They can't calm down on their own. We often don't talk about self-regulation in terms of kids learning to calm their own bodies because it's very much a dyadic process that this protective caregiver is crucial to. When there's the absence of that caregiver and a lot of environmental things in the environment, and we'll talk a little bit about what some of those are, it is as detrimental to the developing brain as prenatal alcohol development, lead exposure, and other neurotoxins. And we have a lot of rules, like don't drink while you're pregnant, like lead paint is really mostly we have to think about it with older buildings, but for the most part, it's the a thing of the past. But we really haven't been talking about the very, very difficult impact of toxic stress on the developing brain. And that's what Child First is about, is to help reduce some of the toxic stress factors. So again, all of these are stressors. And when these happen in the absence of a caregiver that can buffer the effects, and we sometimes think about it as a shield, or if you think about a parent holding a baby underneath an umbrella, these in of themselves are not these are stressors, but as long as we have a protective caregiver, we're actually doing pretty good. And these are a lot of things that are associated with toxic stress, things that we see in our population quite a bit is extreme poverty, domestic violence, trauma, abuse and neglect, parental mental health issues, lack of basic needs. We do see racism and racial violence. So really kind of thinking about the brain is developing in the context of all these, and then the parent is often struggling to manage all of these things and be a buffering effect. So I think that's one of the reasons why we kind of think about intervening early. Because what we found is that toxic stress can cause a rise in cortisol and stress hormones that can harm the developing brain and lead to lifelong problems. It can lead to, as Kathy was saying, adult mental illness, academic failure or learning disabilities, and chronic health problems. You probably have heard about the ACEs study, in which a lot of these early stressors, again, in the absence of a caregiver, have led to increased obesity and heart disease and that kind of thing. And it's especially detrimental when these things occur during the first 3 years. But we like to think about hope in Child First, and we like to think about really that the power of responsive relationships, that caregiver holding the child and protecting them, is really where the hope is. And so part of Child First's mission is to really kind of how that power is building these positive, responsive relationships. So overall, the goals of Child First is to promote both child and parent mental health, promote child development and learning, enhance access to services in the community, and hopefully decrease child abuse and neglect, because some of these same toxic stress factors are risk factors for abuse and neglect. And we do serve children. A lot of times our referral questions are children with emotional behavioral problems, abuse and neglect, or some learning or developmental problems. And it's a 2-generation model. So we work dyadically. We do not do individual play therapy with kiddos, because we find that the most important factor is building up the capacity of the caregiver to take care of the child. So like we mentioned, a lot of these caregivers also face multiple challenges like poverty, homelessness, intimate partner violence, and other substance use and other mental health issues. And we work with moms and dads and foster parents and relative caregivers. I kind of joke and say, like, a kid can't drive themselves, a baby can't drive themselves to therapy. So whoever drove them is the person that we're going to be working with. And since we're a home visiting program, we also, whoever is there in the home and ready to work with us. So we don't limit it to birth parents or mothers. And we really try to figure out who are the protective shields, plural, in these kiddos' lives. So as we kind of we take an ecological approach where the child is the center. So the child is the client, which sometimes thinking about a 1-year-old and do they have a mental health illness that's somewhat philosophical, and the one that I've thought about and talked a lot about. But we also really look at the relationships, parental challenges, and larger community issues, including racism and systemic issues that are then kind of pressing on to the child through these other channels. So Child First is a prevention/intervention, meaning that we're hopefully preventing further problems, but we are looking at intervening at where there is actual like functioning problems for the kiddo. So they're not sleeping, they're not eating, they're not able to go to school, they're preschool and stay there. They're not able to separate from their parents. They've maybe had a lot of medical illnesses. So really kind of thinking about, and I mentioned nurse family partnership, and those take prenatal mothers and work with them through the child's first 2 years. But they're at risk, but there's no established problem. Child First really looks at, there is a problem already. Let's get in there, hopefully address the problem and prevent the problem from becoming worse in the future. So the unique thing about Child First that's different than a lot of typical home visiting programs or even an outpatient program is that we actually take a team approach in which we work on family stabilization and therapeutic intervention at the same time, with 2 team members going into the home and working on these different aspects. We spend a lot of time engaging families, building trust and respect, really where our referral comes from, really kind of like if a family is self-referred, it's usually easy to build trust and respect, but a good portion of our referrals are from social services, in which building that trust and respect is really important, and in engaging people in this. And then we do some family stabilization and connecting to community services, such as do they need CCAP in Colorado to access childcare. We do a very lengthy, a comprehensive assessment looking at children's relationships with their caregivers. We look at their functioning. We also do a brief screening of development in case there's other problems that we might need to refer to early intervention or something like that. And then when we move into the intervention phase, our teams, the clinician typically does child-parent psychotherapy, and our family support partners, who I'll explain in a minute, they'll do parent coaching and some other interventions as a team. So again, thinking about our team approach, and what I like to think about it is that our family support partners are usually bachelor's level individuals that really are about stabilizing the family and connecting them to any resources, be it job training, parent mental health, that kind of thing. And then they also do provide parent coaching as well. And I feel like the family support partners are turning down the heat from the stress in the environment so that the mental health clinicians, which are either masters or doctoral licensed therapists, what they do is they really build up that buffering effect of the caregiver. So if we're thinking about toxic stress, we have the family support partners turning down what's coming at the dyad, and mental health clinicians building up the support for the ability of the parent to actually be the supportive person in the child's life. And we really do, like, we have a lot of mantras about like really building up the parent to be the most important person because they're who are with the children all the time. So we do use child parent psychotherapy, which is an evidence-based trauma treatment. The clinicians do this again to develop that protective, nurturing response and heal from any trauma with children and their parents. Our family support partners use an abecedarian approach. And I'm not going to show the video because sometimes that will get lost in the, oh, does my video showing? But an abecedarian approach is a parent coaching where we teach parents to be highly attentive and language-based with their children, because the research shows that the more you talk to a child, A, the more connected they feel, and B, their language skills also like increase markedly. Our family support partners also work in providing circle of security concepts. We're all trained in the circle of security parenting group, but a lot of times we do use kind of just themes from that versus like doing a whole group. Like we'll pull out, for example, a family support partner might, and circle of security is an attached, kind of gives a visual diagram for attachment relationships that parents really can understand what their children's attachment needs are and how they can meet them. Our FSPs, or family support partners, also work on what I call executive functioning, this idea of planning ahead and doing reflective case management. So in the beginning of a course of treatment, we may actually bring them diapers or a bed for their toddler. But then as we progress, we're like, how can you access these services in the future so that when we leave, we're leaving a caregiver that's actually a little bit more skilled at meeting those needs for their family as much as they can. Because our systems are hard and difficult to access. So that's part of their role, is to really help that parent access them on their own. And I've already mentioned some of these, so I'm not going to spend a lot of time, but these are just some examples of how our family support partners actually really do help families access community services. And I would love to learn how we can partner with you around if you have a specialty in any of these areas, because really we're building relationships and we learn something new every day that we didn't know was available for these families. And I will say that housing and shelter is probably our #1 need, and probably also the most difficult to obtain for families. We started in 2021 and we had a lot of emergency funding from all the pandemic resources, and that has for the most part dried up, and housing, particularly in the Denver metro area, is very expensive and very difficult. And we know the shelters that we know of are also full with families, and shelters available to families is also somewhat rare. So highlighting, I love graphs and data, and just I want to really show you guys that the research, and I took this from the original research and then the updated research that we gather each year. And as you can see that kids get better, their problem behaviors decrease, caregivers are less depressed. By 73% from baseline, which I actually think if a caregiver is less depressed and their PTSD symptoms are better, then they can be more of the buffering effects for their child. And then we see the child social skills and child social skills go up and problem behavior goes down. But I also love to see is that parenting stress, the stress of every day of interacting, feeding, making sure your child is safe actually is significantly decreased. And in the 21 to 22 year, the parenting stress improved by 82%, which is huge. And even more important is that the parent-child relationship is also being reported as they enjoy each other more. And that's one of my personal goals, is that when I see a family laughing that before didn't laugh together, and like that full belly laugh, despite all their, like, I'm like, okay, things are moving forward. We're doing better. That's my own personal, like, they don't measure that in Child First, but that's one of my personal goals, is that the family laughs and enjoys each other. All right, so that is pretty much Child First. It's always, I feel like I could talk far more than I do.
So Jennifer, Sommer Sheppard is going to talk about early childhood consultation. Thanks so much for being here.
My name is Sommer Sheppard, and I supervise the prevention promotion part of our early childhood and family center team. Part of my role is supervising the early childhood mental health consultation team. So this may look familiar. It's actually the same one that Christy shared. However, where early childhood mental health consultation comes in is in a different part of this very same triangle that Christy showed. So instead of being at that prevention and then intervention tier, where Christy's Child First program is, we're working in the prevention and promotion tier. So it looks a little bit different in terms of the sort of work we're doing. And at least hope to be doing. There are times where we definitely get called in and it's really clear from the get-go that this is a child who likely needs intervention. And that's part of our role, is then connecting, the family with resources. If indeed, they do want to proceed with receiving therapy, or if they need speech or OT, number of different services. So who are early childhood mental health consultants? So mental health consultants are all licensed, eligible, or are fully licensed mental health professionals who have expertise in early childhood, as well as social emotional development and mental health. But again, working more from that prevention and promotion angle instead of the actual intervention tier. Most commonly, we work with early childhood, various professionals, providers, as well as caregivers and parents. So we support them in overseeing the well-being and the health of the kids in their care. However, one big differentiating factor is that we don't actually work directly with the children that we get called about. We work with the adults who are supporting those kids. We don't, do assessments, make a diagnosis, provide therapy to the kids. And I think that's one big point of clarification. A lot of times we'll get calls wanting us to go in and, do therapy in a child's classroom, for example. And it's not, even though people oftentimes in this role have experiences as therapists, it's not part of the scope of the consultation program. And I think also referring to back to something that Christy had said earlier, is that, regardless, the work in this early childhood stage would be dyadic. So it would be with the parent, not just going into a classroom. And so that's one thing that, really differentiates our role. So where are consultation services available? I know this is tiny, and I'm happy to, kind of to put a link in the chat. But basically, the simple answer is throughout the state of Colorado, between either philanthropic, and different grant resources and funding, as well as state-funded consultants. We, in essence, cover the state. So as far as Aurora Mental Health and Recovery, we cover Arapahoe, as well as a part of Adams and more rural Arapahoe County from a different funding source. But regardless of where, potentially services may be needed, as far as consultation goes, there is a consultant within, within every county. So again, if you care for young kids, we can help. There are a number of different ways that consultation has actually tried to have a little bit more of a prominent footprint as a state. One of them is by establishing a support line. And so this is provided by Colorado Department of Early Childhood. And like any of our services, it's no cost. And it's confidential for kids, for people who care for kids under 6. That may be the parents, that may be foster parents, family members, childcare providers, and I'll show kind of beyond that. In a few slides, we also are looped in with other people that are doing different work in the community, such as child welfare and DHS. So the support line can also help you, better understand and support the well-being of the young kids, as well as struggling. And I think this is one of the really key parts of our role, is that, we will go in, teachers will say, I'm having difficulty with this, or a parent will say, I'm really struggling. I'm not sure if it's just because he's 3 or if this is something I should be concerned about. So a lot of times we do observations and can really help the parent or the provider think through some of those questions they maybe have, some of the concerns, and, help them make determinations. Do they want to have an assessment, or is there, a trauma history where perhaps they do want to have therapy? So in that case, we'll connect them, or maybe frankly, it is just that the child is 3 and they're pushing boundaries and kind of testing some, and is really just developmentally appropriate, in which case we'll support the parent and any other adults that work with them, in order to have the child, kind of work with the child through some of those pieces, and have them be successful. So as far as actual consultation, it begins with a short conversation between the professional or the parent, whoever's calling, and the local consultants, just to discuss whatever needs they have, any kind of support that can be provided. Sometimes it really goes no further than the support line. Sometimes they make a determination that, okay, yep, this actually is developmentally appropriate. If we continue to have challenges, we'll call back. And other times it will actually turn into a referral that is then sent on. So some common reasons that we get called in and services we provide: assisting families with referrals for desired services, such as early intervention, child find, or therapies of various types. Providing support for other early childhood professionals. connecting providers, families with resources. And we also, there are a number of overlaps you'll kind of see between Christy's team and what they provide and some of the things that we provide as well. Circle of Security is one of them. Oftentimes there will be childcare providers who will want their parents to have access to this group. And so we'll do a formal group for childcare providers, there's, teams. And in addition, there is a specific classroom Circle of Security, and we have been providing that. Just noting the difference that, oftentimes teachers or providers, instead of having one or maybe two kids that they're really wanting to meet the needs of in terms of like the parenting group, they have a classroom of 10, they have a classroom of 15. And so how do we really conceptualize that and make sure that they're able to meet those needs? We also provide reflective consultation in addition. So a couple of the most common people that we support are parents and caregivers, and then early childhood professionals. For parents and caregivers, we want to be able to increase that ability to support their social emotional development, identify and address mental health development issues early on, and decrease any kind of child behaviors that the parents and the caregivers are finding challenging. As far as the professionals, we really would like to be able to encourage and promote a warm and responsive care environment, reduce and help those providers cope with stress, as well as reducing suspensions and expulsions. So the next few slides specifically pertain to suspensions and expulsions, other types of exclusions. This is research that was done by Dr. William Gilliam at Yale. And he has done an extensive amount of research on early expulsions and as well as, what the result of those expulsions can be. So using his information, there can be harm to children now as far as suspensions and expulsions go. Denying access to early ed, undermining the child and family relationship with schools and education, obscuring root causes that actually need to be addressed. Again, I think a common one potentially being trauma. There may be externalizing behaviors that childcare sites are having difficulty managing, and trauma may very well be at the root of that, but isn't being addressed because it's simply the externalizing behaviors that they're seeing. And it also can further calcify biases regarding who we serve, whom we exclude, so on and so forth. As far as some of the things that can happen as a result later on, there can be academic failure and disengagement, school dropout, and increased rates of law enforcement contact and later incarceration. So I'm just curious, I'm going to stop sharing for a minute. Does anyone have a sense of what the rate of expulsion may be in kind of early care and education environments as opposed to, looking at K through 12? Any thoughts, just generally speaking, about where that might land? Higher, lower? Higher. Kathy says higher. And Kathy is absolutely right. So I'll go back and share my presentation. I think, those of us in the field, it's not necessarily hugely shocking that it is higher. However, the extent of the difference, I think, oftentimes catches people off guard. So expulsion rates from childcares are obviously significantly higher than K through 12 and pre-K. So, specifically, the rate per 1,000 children in those different types of environments, you're looking at about 2 kids expelled per 1,000 in the K through 12 range. And when you go to childcare, it's almost 27 and a half per 1,000 children enrolled. There has been a link established between teacher stress and expulsion. And so, as you can see, percentage of classrooms expelling for teachers that self-identify as having low stress, the percentage of classrooms that expel is about just shy of 5. Average stress, it goes up to 9.3. And then high stress ends up being above 14%. And so this is one of the areas where we really hope to be able to make a difference, in that if we can reduce that teacher's stress, provide support for them, the hope is that they in turn will have a higher capacity to really be able to support the kids in their environment, regardless of what their needs may be. So again, from Dr. Gilliam, a few Department of Education, Office of Civil Rights, statistics. Black children make up only 18% of preschool enrollment. However, 48% of kids who are suspended more than once. And boys also receive 3 out of 4 out of school preschool suspensions. In 2016, Black preschoolers were 3.5 times as likely to be suspended as white preschoolers. And again, representing 19% of preschoolers, but 47% of suspensions. Boys represent 54% of preschoolers, however, 78% of suspensions. So just kind of a summary, who typically does get expelled? 4-year-olds are far more likely than 3-year-olds. Black preschoolers are more than twice as likely as white preschoolers, and boys are more than 4 times as likely as girls. So what are some of the ways that we provide support in these different environments? One is supporting well-being for caregivers of all types. Our thought and belief really is that all kids benefit when their caregivers are healthy and they're not too stressed, be it a childcare provider, a parent, a family member, whoever that adult may be. So the hope is to really support the growth and well-being so that we can reduce teacher, director, and stress and increase staff retention. We're also supporting, well-being for all children by increasing the confidence and ability of early childhood professionals and caregivers to support healthy social emotional development. And the skills caregivers learn become more automatic over time. And that's really the hope, is that with consultation, some of those things that have to really be thought about and be very intentional and feel, at times maybe demanding on the part of the teacher, suddenly become just part of something they do. It can even be as simple as greeting a child by name when they arrive in the morning, or, providing different sorts of supports when they're giving directions, telling kids what to do rather than what not to do. And also being able to kind of detect and potentially address and refer as needed for mental health and developmental issues early on. Around addressing challenging behaviors, we can work with the caregivers to support the kids that are in their environment who may be struggling. This helps to decrease behaviors that adults find challenging, as well as reducing those suspensions and expulsions, which is really key to the effort of consultation. So one of the quotes that I think many of us in infant mental health and in consultation as well really kind of hold dear is the platinum rule. I think, most are probably familiar with the golden rule, but this is a little bit different. Do unto others as you would have others do unto others. And so we want to go into whatever environment it may be and support the people who in turn support the kids. So if we're able to kind of provide that sort of support that we hope families and kids are able to receive from those professionals, then they in essence are better able to pass that on. If their stress is such that they're really not able to attend to those needs and don't feel supported themselves, the chance of them being able to support the kids is significantly less. So it's kind of a list of ways that, working together, consultants can help in the caregivers. It can be professional development. It can be, and oftentimes is, early care and education. However, the state really has expanded and has encouraged us to reach people who are not in early care and education. And that's something I think that my team is really being intentional about. Identify needs and work towards specific goals. Again, supporting classrooms, individual kids. We provide workshops for families or professionals, conduct developmental screenings, and then again, resources and referral to whatever sort of community services may be needed. So I think this is a really common question. When do we call? From the state's perspective, what they would say is call when everything is fine. Consultation is relationship-based work, and it can be really difficult if we're called in, kind of right at the time that there's the potential for a child to be expelled, to then try and establish a rapport with the teacher, a rapport with the director, a working relationship with the parent, in time to be able to kind of interrupt that process. Whereas if it's something that we, if it's a place we've been working from the beginning of the year and have been informed of some of these difficulties, it's much easier because that working rapport and mutual respect is already established. And like it says, when you build a relationship with the local consultants, you receive ongoing training and support. The hope being, that we can head off some of these challenges. It's also appropriate to call when people are feeling overwhelmed by the demands of caregiving. We are, trusted, reliable partners who can listen and really help support people in their own health and well-being. Because obviously, and I'm sure you've all heard of the, putting your own oxygen mask on first on a plane. Very similar in the sense that, our philosophy is that if people don't have their own oxygen mask on, so to speak, then they're not able to assist their child. Also, if there's just more information needed, we can work with, people in all different types of environments to develop approaches to support individual kids, including those that may be struggling. So again, much of the work historically has been early care and education, and the state's really hoping that we're able to expand further beyond that. So a few other people and organizations we consult with includes DHS and child welfare, pediatricians' offices, early childhood councils, LCOs, especially now with universal pre-K becoming part of this, health consultants, coaches, and licensing, as well as other mental health professionals. So my contact information is listed here, and I just want to thank everyone and make sure that we have time to kind of just shift to Q&As.
Thanks, Jen. There are a couple of questions in the chat. Maybe we can start with those, and then others can jump in. So Amy asked if she's curious if the rates of expulsion are higher in childcare facilities that don't have a high ratio of teachers to students, if that ratio makes a difference.
Really great question. I've found that it just in my own personal experience, it seems much more linked to kind of stress and burnout just across the board than it really is specific ratio. So, sometimes it'll be that there are providers that have great relationships with their assistant teacher, their co-teacher, and even though they have, a higher ratio, they just have a way that it's fluid and it works, and they're really able to support those kids. And other times the ratios may not necessarily seem particularly high, but for whatever reason, that provider is struggling. And so I think it goes much further beyond ratios.
Makes sense. And then a question if you all are part of COAIM, or Colorado Association for Infant Mental Health.
Yes.
And isn't that what the credential is associated with? Can you explain that a little?
So there's an endorsement process, and that both Jen and I both have it, but even some of our therapists and Jen's consultants have, and the endorsement is to prove that we have specialized knowledge and experience in working with the birth to 6 population. So it's a rigorous supervision, a test, and kind of, the ultimate blessing that you see on both of the end of our names with the extra letters.
Great. What other questions do folks have? Feel free to just take yourself off mute or raise your hand. Or
I had another question actually about the daycare, childcare situation. Are you coming across maybe there might be some situations where maybe the providers of these childcare facilities are not equipped or trained to work with children who are a little bit more challenging due to their their environments at home, and therefore that dropout rate is happening more frequently, and then that's why the providers are burnt out and can't keep up on that care for that child.
Yeah, really, truly, we expect a lot of our care providers. They, truly are not, they're not therapists. They're not, like in all of these different categories where we really have a lot of training and specialization in some of the more challenging behaviors. And yet oftentimes the expectation is that they have much of that information and specialty. And so that's very much where consultation, I guess in my hope, in my kind of optimism comes in, is that we are able to support the providers in, whether it's through professional development, whether it's through just having that supportive relationship. And they can say, last week was so hard. And then we can kind of reflect and talk through some of that with them. But yes, oftentimes, the providers are going there with the intent of just working in a classroom environment. And I think it ends up being much more than that on a pretty regular basis.
thanks. Other questions? Comments?
Kathy, I was just going to point, I know there was a question that came through earlier. I believe it was Christy, when you were speaking, that Mandy asked, and I know that you kind of answered the question with one of your slides, but the question was, how can community-based organizations and healthcare providers support your work and ultimately the mental health of our kids? And you did talk about on your Connecting Families slide, but it might be a good opportunity to emphasize again ways that organizations can help or help connect you with resources, or what resources are needed.
That's a big question. So we really, I think part of it is that we sometimes don't know. In our Child First program at Aurora Mental Health and Recovery, we don't know what's out there always, or exactly the process for funding those resources. For example, we've been looking for some respite providers, and then we're struggling to figure out, well, how there's a special for for little kids, there is a program that we kind of luckily discovered. But so really, if you work in this early childhood world or have people coming in, we would love to build a relationship with you so that we can mutually like send them over to, like, if you're an early intervention, send them that way. And then a lot of times what I have is I invite guest speakers to our Child First team supervisions to really kind of talk about like who are you and what resources. And we're very relationship based, so we kind of like to meet you and invite you in to come talk to us so that we can again develop a partnership over time, that so that we can help meet these needs for these families. And so yeah, so I would love to, and I'll put my contact information in the chat. But I would love to like invite you and talk to you and be relational and have you over for coffee with the rest of the team, including we have 4 family support partners. So, and they are amazing at finding new resources. But yeah, just we'd love to get to know you and how can we join together in helping these families.
Thanks. There's also a question from Mary about the best way to refer families to either program. And then I noticed Jen added her contact information for consultation. Any more from either of you? Or I noticed Daryl, you've jumped on the screen too, about how to make referrals.
I will also put, there is also a website that for Child First in the actually the statewide, and they will appropriately, depending on the parent's address, refer you to either Aurora Mental Health and Recovery or one of the other 2 metro sites of Child First. And there's also a site in San Luis Valley and a couple other sites that are just getting up and started. But it's a centralized referral place, so that the family actually gets to the agency or affiliate agency that covers that area. So I will stick that in the message as well.
Sounds good.
Similarly, I'll drop the kind of the link for the statewide consultation, kind of contact information. There's a referral form. So if indeed someone does have, maybe there's a family that's moving from Arapahoe County and they're going, up to Larimer, and they want to connect with a consultant in that area, this would be a form that regardless of where they are in the state of Colorado, they could fill out and request to get consultation.
That would be great. Thanks again, Jen and Christy, for your time today and your excellent presentation. Really, really appreciate it.